Hello everyone, my name is Snehal Garg and I'll be presenting on our poster titled Case of Vaccine-Induced Thrombotic Thrombocytopenia Following Moderna COVID-19 Booster Vaccination. COVID-19 vaccines, especially the mRNA vaccines, have been crucial in controlling the pandemic. These vaccines deliver a piece of genetic material that instructs cells to produce the SARS-CoV-2 spike protein, which then triggers an immune response. While the benefits of vaccination greatly outweigh the risks, rare hematologic complications have been reported, including thrombocytopenia. Our case describes an example of vaccine-related immune thrombocytopenia, or VRITP, following a Moderna booster. The patient was an 81-year-old woman with a past history of lung cancer treated with lobectomy over 20 years ago and carotid stenosis for which she was taking aspirin. 3 days after receiving her Moderna booster, she was presented with bleeding blisters and petechiae in the oral cavity, petechiae on her lower extremities, as well as hematuria and hematochezia. She had no family history of bleeding or clotting disorders, did not smoke, and had no recent medication changes. Her initial laboratory evaluation was remarkable for profound thrombocytopenia, as platelets were found to be less than 2,000 per microliter. Other values, including coagulation studies, fibrinogen, D-dimer, and pertinent CBC values, were also listed in the chart on the left. Given the severity of her presentation, we performed an extensive workup to rule out other causes. She tested negative for viral infections, including hepatitis, HIV, EBV, and CMV. Heparin-induced thrombocytopenia antibodies were negative. ADAM-TS13 activity and LDH were normal, which excluded thrombotic thrombocytopenic purpura. Imaging showed no thrombosis or bleeding, and GI evaluation, including colonoscopy and H. pylori testing, was unremarkable. Other autoimmune and bone marrow disorders were also excluded. Taken together, these results pointed towards a diagnosis of vaccine-related immune thrombocytopenia, established as a diagnosis of exclusion. In terms of management, aspirin was held and the patient was transfused with 2 units of platelets. She also received 40 milligrams of IV dexamethasone for 4 days, along with 4 courses of IV immunoglobulin. Her platelet counts gradually improved, reaching 156,000 per microliter by day 8. This case highlights the distinction between vaccine-induced thrombotic thrombocytopenia, or VITT, which includes both low platelets and thrombosis, and VRITP, which involves immune-mediated destruction of platelets without thrombosis. Our patient had no evidence of clotting, supporting VRITP as the diagnosis. To put this in context, as of February 2021, over 18 million Pfizer doses and over 16 million Moderna doses had been administered in the United States. There were only 15 Pfizer and 13 Moderna cases of thrombocytopenia reported, which corresponds to about 0.8 cases per million doses. This rate does not exceed the background incidence of ITP in adults, which is about 3.3 cases per 100,000 people per year. The temporal relationship to the booster dose strengthens the likelihood of vaccine involvement. Possible mechanisms include molecular mimicry, exacerbation of a subclinical disease, or immune activation triggered by vaccine components. While rare, reports like this emphasize the importance of clinical awareness, ongoing monitoring, and timely management of adverse events. This case underscores the importance of recognizing vaccine-related immune thrombocytopenia as a potential but rare adverse event. Early diagnosis, exclusion of other etiologies, and prompt treatment with steroids, IVIG, and platelet transfusion led to recovery in this patient. And it's worth reiterating that despite rare complications such as this, the overall benefits of COVID-19 vaccination far outweigh the risks.